The adrenal gland sits atop the kidneys and produces steroid hormones as well as catecholamines, essential for our stress response, as well as blood pressure regulation, electrolyte balance, metabolism, and immune modulation. Clinically, most pathology arises from either excess or deficiency of cortisol, aldosterone, or adrenal androgens. The adrenal cortex has three zones. The zona glomerulosa makes mineralocorticoids like aldosterone. The zona fasciculata produces glucocorticoids such as cortisol, and the zona reticularis produces adrenal androgens. Knowing which layer produces what helps us to localize pathology based on which hormones are either elevated or deficient. All adrenal steroid hormones derive from cholesterol, and the first step is conversion to pregnenolone. And this occurs in the mitochondria and is rate limiting. From there, steroidogenesis branches into three separate pathways depending on the enzymes present in each adrenal zone. Enzyme defects or enzyme overexpression can create distinct clinical symptoms and syndromes. Looking at pregnenolone, it is the precursor to all steroid hormones, progesterone, estrogens, androgens, and glucocorticoids, as well as mineralocorticoids. Clinically, you rarely measure pregnenolone directly, but understanding its role helps you interpret patterns in adrenal fatigue discussions, congenital adrenal hyperplasia, and steroidogenic enzyme disorders. This slide is showing the kind of full completion of steroidogenesis in the adrenal gland, and it's to remind us all that cholesterol is our starting substrate for all hormones made in the cortex. And we can see this up here. Cholesterol is what starts it all. Any condition that impacts cholesterol availability, such as statin use or even poor nutrition, may theoretically impact adrenal output. Although clinically, the body prioritizes steroidogenesis pretty heavily and will often rob cholesterol from other stores. Here we can see the branching pathways where cholesterol can lead down to its other components. Cholesterol leads down to pregnenolone, which leads down to either DHEA or progesterone, and eventually gets us our glucocorticoids, mineralocorticoids, and sex steroids. From a clinical standpoint, disruptions in one branch, so any one of these branching points, can push precursors into another, which can lead to hormone imbalances. For instance, if I have a block here, I'm going to have a buildup in progesterone here, and that in theory could push progesterone down these other two pathways more. Um, it's important in interpreting different adrenal hormone disorders, especially dealing with the cortex, as well as certain patterns that are seen in different conditions, including conditions like PCOS, polycystic ovarian syndrome. DHEA is produced in the adrenal glands, the gonads, and the brain, and it peaks around age 30. It's the most abundant steroid hormone. Clinically, a low DHEA level may correlate with immune dysfunction, chronic illness, metabolic disease, mood disorders, and low libido, and it becomes especially relevant in chronic stress and adrenal insufficiency. This next slide highlights the conditions that are associated with a low DHEA level, everything from autoimmune disease to hypertension, depression, and osteoporosis. It's also suppressed by stress and high cortisol states. When interpreting labs, a low DHEA in a stressed patient can indicate chronic suppression of adrenal androgen production. And this diagram shows how DHEA fits within the androgen and estrogen biosynthesis pathway. DHEA can convert into androstenedione and then into testosterone or estrone. Clinically, this is important because disruptions in adrenal output, such as an adrenal insufficiency or chronic stress, reduce downstream sex hormones. Conversely, adrenal hyperactivity or enzyme imbalances can elevate androgen levels, contributing to conditions like hirsutism or polycystic ovarian syndrome. When we come back, we will look at some of the functions of aldosterone as kind of our next step in our look at the adrenal glands.